Welcome to OncoPharm. I'm your host, John Bazar. I am a professor of pharmacy practice at ETSU's Bill Gatton College of Pharmacy, and this podcast is sponsored by Kelly C. PharmD, an oncology education company for pharmacists. We are back from HOPA's annual conference, which was in New Orleans, Louisiana. Wonderful time in NOLA, as always. We'll kind of do a recap of the comings and goings of HOPA. But first, let's talk about, kind of what caught my eye as far as, really what I learned at HOPA, or learned, first, in some cases, things I did not know and just learned. And at least in one case, something that made me think about something at a much deeper level than I had before. So some of the things I learned were the availability of some data to support intrathecal drugs beyond cytarabine and methotrexate for things like leptomeningeal disease. And this was a wonderful presentation, and there's some data for IT thiotepa and IT pemetrexate and IT topotecan. Now, is the case, as you might expect, for something that's kind of an odd thing. These are very small studies, maybe 40 patients at the larger end. But if you really needed to try to justify it, there are some literature for some of these things. Certainly makes sense that thiotepa would have some activity, knowing how lipophilic it is and how this comes through every, will cross the blood-brain barrier. So it makes sense that there's some safety with thiotepa IT. There's some good stuff out there for a while about intrathecal trastuzumab for HER2 amplified breast cancer, but I wasn't aware of any data at all for thiotepa, pemetrexate, and topotecan. So that was useful to know. And then it's a pretty easy thing if you file that away in your brain to go back and look for if you need it. There's not going to be a lot of studies or publications with intrathecal thiotepa or pemetrexate, for example. One of the other things I learned among the many great talks was about the risk of CMV reactivation in patients receiving BCMA targeting bispecific agents. And so pre-emptive CMV monitoring starts with first checking CMV regularly. And then when you start to CMV titers rise, put them on a drug for CMV. We've done this with letermovir, recently in a patient, not a BCMA target drug, but a different scenario. But then, of course, you have valganciclovir and ganciclovir that have a lot of myelosuppression. But at least watching for that, I heard several people talk about how they got, after the presentation, they were burned by that because they weren't monitoring CMV. Patients come in having trouble, they have pancytopenia, and some ID doc does a CMV titer and it's sky high, and they have CMV reactivation. That was the cause of the myelosuppression, not some sort of disease or direct drug effect. So something to keep in mind for those of you doing, BCMA or bispecifics with myeloma. Speaking of myeloma, James Davis and a group of folks have done kind of a multi-center observational study looking at the safety of the MMR vaccine in folks on daratumumab after transplant. So this, you after your auto transplant, you start a few weeks, afterwards with your non-live vaccines, and then you wait to 24 months to start to revaccinate with your live attenuated vaccines like measles, mumps, rubella, or MMR. So they were saying, hey, this is kind of a new thing now, doing dara maintenance long term. Is it safe to do this? And this is, of course, very pertinent with measles outbreaks in the country. We thought we had measles beaten, and now we know only America can snatch, we won the war on measles, and it should have been over, but now we're losing because of decreased vaccination rates to measles. I think, my favorite talk where I learned the most was about really getting into the weeds. It was a BCOP talk, which is really what you want in a BCOP talk, about immune-related adverse events and monitoring them. And kind of it seems obvious to me in hindsight. It's one of those things like, I should have thought of this. But, when like ipilimumab first came out, one of the things we learned early on is if you have an immune-related adverse event and you get treated with steroids, it doesn't necessarily negate the benefit of the drug. Okay, but there's a wonderful image they have in this talk. And this was Emma Jones and Jordan McPherson. And it's a little curve that looks like, all right, so you give somebody an immune checkpoint inhibitor, and if you have no immune-related adverse effects, you have probably the lowest chance of long-term survival. If you have immune-related adverse events that require immunosuppression, you have a little bit better effect, right? But if you have immune-related adverse event and no need for immunosuppression, then you do the best. And this sounds a lot like if you've done an allogeneic stem cell transplant rotation. Every transplanter wants their patient to have just a little bit of graft versus host disease, like grade 1 something that you don't really have to do anything with, maybe just some topical steroids, just a small percentage. Like, you want some of that immune activity as a marker that you're getting something. And so what we now seem to know is that the longer you're on steroids and the higher dose of steroids you're on, you're going to blunt the benefit you get from your immune checkpoint inhibitor. And so there's you start your steroids right away, but you want to de-escalate your steroids. And if you need to, use other, what we might call in rheumatoid arthritis, disease-modifying agents to be steroid sparing, so you can still allow your T cells to work. And what was clear to me in hindsight, as I pointed out, is the drugs that we're using are really tailored or extrapolated from the autoimmune disease space. So infliximab for immune-related colitis is from the irritable bowel disease or inflammatory bowel disease data. And so now we have some data even, infliximab and vedolizumab are drugs that can be used for immune-related colitis after, say, nivolumab or nivo plus ipi or pembrolizumab. And infliximab works a little bit faster, but has a greater risk of infection than vedolizumab. So you can kind of use that to tailor which one you might use and when. We have this kind of devastating syndrome where you have myasthenia gravis and myocarditis and myositis, and abatacept and ruxolitinib in combination, and high dose abatacept has some compelling data that it might be effective. There's even a phase 3 trial enrolling on this, and I think I looked this up at the time when I saw this, like a phase 3 study for immune-related myocarditis. That's a very rare adverse effect, and to try to do a phase 3 study when you're trying to recruit 300 patients is very ambitious, and I hope that study accrues because that's going to offer a lot of great information. I also learned that if you have immune-related hepatitis, that mycophenolate mofetil is probably the best drug to use, certainly better than something like than azathioprine. So there's more data out there about how to deal with this, and so this was a really, really great talk to help with this. Some of the things about IVIG for pneumonitis, looks like 5 people in that study got IVIG, kind of hard to extrapolate from that. But there are a lot of different options you have beyond steroids. And that was kind of the point of this talk. Once you're steroid refractory, what do you do, right? And so you kind of have to pull from observational studies and do the best you can. So whether it's cutaneous, there's some compelling data for dupilumab for cutaneous immune-related adverse events, tocilizumab for there's arthralgias and things like that. But kind of the key point here is you're trying to balance, and we're good at this in oncology, walking that fine line between efficacy and toxicity, balancing that fine line between tamping down the immune response, but not so much that we negate the benefit for our immune checkpoint inhibitor. And then the last thing I learned was a very, very specific clinical pearl based on a study of 10 patients on semaglutide, high-dose semaglutide, so 2 milligrams of semaglutide taking alectinib, which is an ALK-targeting tyrosine kinase inhibitor for ALK-rearranged non-small cell lung cancer that requires the drug to be taken with food for absorption purposes. And if you're on a GLP-1 and you have decreased appetite and you're not eating, you might not eat as much and you might not get as much drug exposure. And so there is a small PK study showing that there's a 30-some% decrease in exposure total of alectinib in people on the higher end of semaglutide dosing. Perhaps you might extrapolate that to other oral oncolytics where the absorption is low, where bioavailability is low and absorption is dependent on food, like say venetoclax. Certainly venetoclax is a drug that's used a lot. GLP-1 agonist drugs that are used a whole lot too, so maybe a compelling observational study that somebody could do. Of course, with venetoclax, what you can do is you can see are they having myelosuppression or not. With alectinib, you can't really, there's no obvious pharmacodynamic target for are you getting enough drug. With venetoclax, if your counts aren't being touched, you're not getting enough venetoclax because we know what that drug does to the bone marrow. If you're listening to this podcast, you probably tune in because, you're maybe new to oncology, you're trying to get up to speed, try to appreciate the quick weekly updates to help keep pace with the onslaught of new information on oncology. Maybe you just learned about this podcast at HOPA, and you're like, oh, this sounds like something I would like. Well, if that does sound like you, I would check out the Oncology Insights newsletter, a free weekly email written by fellow OncoPharm Kelly Karlstrom, who is the founder of Kelly C PharmD and the ELO Collaborative Program. Each week she shares practical pearls, ways to think through oncology concepts without just memorizing guidelines, and insights on staying motivated and growing in your practice. It's written by a pharmacist for pharmacists, and it's easy to read. You can sign up using the link in the show notes of this episode. So, Nola, I did a little New Orleans preview. Made it to some place I hadn't been before in New Orleans. Nice run along the river, even beyond the river. Saw some interesting stuff once you get past the riverfront park on your run. There's some interesting sights in New Orleans. I added 5 letters, credentials to my email signature at HOPA, receiving the Fellow of HOPA designation, which is a wonderful honor. But the highlight was I had a former student who was on the committee that decides this call me and say, hey, you were selected for this award, which was great. I hadn't talked to her in a while. I had 7 former students, 7 former College of Pharmacy students there, 1 former PGY1 resident. So hanging out with them and catching up with them was great. But really the highlight, there were 2 students there, 2 former students who I didn't know were going to be there, who I didn't know had become oncology pharmacists. One of whom, this was their goal in pharmacy school more than a decade ago, and life happened, didn't end up going and doing a PGY2 in oncology after PGY1, but finally found a job in oncology pharmacy, came to the first HOPA, and came up to be doing the first session. It was great to see. Wonderful to let them know about the podcast. They got like almost 10 years worth of stuff to go back and listen to now. So that was wonderful. Was able to take a wonderful picture with all the alumni there. So that was really, the highlight was catching up with former students, catching up with, my HOPA friends and colleagues. And the first time I went to HOPA, we didn't have the HOPA buddy program, so it took a while to kind of find people to hang out with after the sessions or between the sessions to talk to. And it's gotten to the point now where there's less of a need or desire for me to make new contacts, to network and find stuff. And now I'm trying to find enough time to maintain relationships and folks that I see over the years. And I wasn't able to talk to everyone that I wanted to talk to, or for as long as I wanted to talk to folks. There are a couple of cases where I would just catch someone during what was supposed to be a coffee break, and maybe there wasn't coffee. Maybe I said that on a conference survey. And I said, "Oh yeah, great seeing you. I'm sure we'll see each other later. Would love to catch up." And there just wasn't time to do that, and so that was unfortunate. But I guess it goes with going to HOPA so many years and making so many great contacts and having so many folks you can reach out to when you have questions. So that's a wonderful part of being active in that organization. So thank you all who were there, who came up to me. The guy on the bus who said, "Oh, I love your podcast. I've grown so much as a clinician just from listening to it," which is great. I hope that's true. That's wonderful if that's true. But those kind words are helpful during a busy season, trying to continue to keep doing the podcast. Motivates me to keep doing it, so I always appreciate that. So thank you for listening. You can follow me on X at FromDeepNib and on other social media platforms at OncoPharmPod. And until I talk to you again, remember, doses matter.